So good afternoon, everyone. Welcome to Grand Rounds at a new location. We have Dr. Scott McGinnis here. We're going to have Dr. Demoto O'Reilly, as a former trainee, provide the introduction for him. So thanks for coming again.
Yeah, I'm excited to introduce Scott, who taught me well, and then we also had the chance to work together at both Brigham and MGH. So Scott did his undergraduate at Stanford, and then did his medical degree down at Baylor, and then has been in Boston ever since. So he was at Beth Israel for his internship, and then he was at Brigham and Mass General, both teaching hospitals of Harvard Medical School for residency, fellowship, and now he primarily sees patients at the Brigham and does research at Massachusetts General Hospital. So at the Brigham, he's the director of the Center for Brain-Mind Medicine Seminar Series, and at Massachusetts General Hospital, he's the director of clinical trials at the Frontotemporal Disorders Unit. And he's actually involved as a site PI and co-investigator of multiple clinical trials in both Alzheimer's disease and non-Alzheimer's dementias. And so we'll be hearing about some of these studies today, which are both interventional and also looking at different biomarkers, both imaging and biofluid markers for these diseases. He did serve as the primary discussant in a joint medicine neurology clinical pathologic conference at Brigham and Women's Hospital, which involved a case of a rapidly progressive dementia. And this case was written up as a clinical problem-solving exercise in the New England Journal of Medicine, and was also presented as an interactive medical case on the New England Journal of Medicine website. So you can check them out after this. Without further ado,
thanks. Thanks for the intro. Thanks very much for the invitation to come out here. It's been a very informative day, and it's been great to actually see and meet with everybody. I've enjoyed it a lot. I hope the title of this talk is not too esoteric. I didn't want to kind of scare people away. What I really want to do is talk about material that hopefully everybody sees as relevant. And I'm going to start, with a premise really that we as clinicians and clinical researchers, the way that we routinely think about Alzheimer's disease is oversimplified. I know that we like things to be, I think the famous quote is, everything should be made as simple as possible, but not simpler. And I think it's definitely good for us to simplify, but I think we need to kind of be aware of the hazards of oversimplification. And I think that the traditional way of thinking about Alzheimer's disease has drawbacks, both in our immediate clinical efforts, providing care to patients, and then definitely fundamentally in our research efforts as we try to develop more effective disease-modifying therapies, or effective disease-modifying therapies. So in terms of kind of layers of complexity, mostly what we'll talk about today is clinical heterogeneity. So heterogeneity of presentation. This would be just kind of different symptoms that people would have with Alzheimer's disease. Maybe the fact that we see at different ages of presentation, different rates of progression. A lot of different sources of clinical heterogeneity. Underlying that would be neuropathological heterogeneity, which might be heterogeneity in terms of how the molecular pathology is distributed. It might also be the other types of things that one might see under the microscope, in addition to your amyloid plaques and neurofibrillary tangles. And then finally, I think the conceptualization is more that there's pathophysiological heterogeneity, and we would probably be better off as thinking about it as a final common pathway where there would be multiple potential routes to get there, and that's going to underlie the neuropathological and the clinical heterogeneity, and that eventually our more successful treatment approaches are going to be more specific to the mechanisms that are operable in individual patients. And I think before we move on, I think it does, there are a lot of people around here who know a lot more about this than I do. I think it's in line with a lot of the thinking and the ideas about really trying to obtain the best phenotyping possible of our patients from a genetic standpoint and in every standpoint. So where do we make clinical errors? I think that really one way to think about it is that not considering the distinction between a clinical and a pathological diagnosis would be kind of a root cause in many cases. I think that the terms can kind of be conflated somewhat because they can be used synonymously. People might use the term Alzheimer's disease in reference to a clinical diagnosis that they make, and obviously the gold standard is always going to be the neuropathology. People, neurologists, we all know, I think, in the way that we think, is that what we see is really a result of the localization. That's the fundamental determining factor, and then the localization and time course of a presentation are going to be really important kind of means of making a clinical diagnosis. That's why history and exam are so important. But the fact is that if you've got a similar localization of different pathologies, then you might have a similar presentation. So you might actually call something Alzheimer's disease that might be actually something else that just looks like Alzheimer's disease because it has a similar localization. You might have another type of error where there is similar pathology that's distributed differently, and so an example of this would be the kind of the atypical presentations of Alzheimer's disease where the patient has plaque and tangle pathology, but maybe they're presenting with kind of higher visual symptoms or apraxia or aphasia, and I think the tendency there is, oh, this is an Alzheimer's disease because the person's memory is okay. And then kind of a third error is the failure to consider the fact that pathologically many times people do have more than one pathology, and may even, in our pathology reports, they might have enough of the secondary pathology that there really are two pathological diagnoses. I recently cared for a man who had Lewy body disease as his primary pathological diagnosis, but he also had Brock stage 4 plus Alzheimer pathology. So I think my third. Oh yeah. So this slide just I show a little bit here. This is from Bill Seeley's paper in Neuron, where he was kind of one of the first papers which he was kind of illustrating this network degeneration idea, where there is substantial overlap between the pattern of atrophy of a neurodegenerative syndrome, the patterns of functional connectivity derived from resting state fMRI data, and then the structural covariance, and that would be in healthy people, and then also in healthy people, just structural covariance, looking at kind of which regions of the brain covary. And when you look at these clinical syndromes, AD and the behavioral variant of FTD and semantic dementia, progressive non-fluent aphasia and cortical basal syndrome, there appears to be kind of a selectivity of these neurodegenerative syndromes for these large-scale networks. But again, these are syndromes. These are not pathological diagnoses. And especially when dealing with, there's a variability in terms of how well each of these syndromes, predicts an underlying pathology. In a case of like semantic dementia or semantic primary progressive aphasia, it's a relatively predictive syndrome for a specific subtype of TDP pathology. On the other hand, cortical basal syndrome is kind of notoriously heterogeneous, and you can have a patient who meets the kind of clinical appearance of a cortical basal syndrome, and it might be cortical basal degeneration, it might be Alzheimer's disease, it might be FTLD with TDP pathology. So that's where some of these kind of clinical way of thinking comes from, I think, is the fact that historically we have had to rely on symptoms and signs more, and this was kind of before the revolution of biomarkers that's become available more recently and is ever expanding. And so if you look back to kind of the prior iterations of clinical diagnostic criteria, this would be the NIN, CDS, ADRDA criteria for AD. You're looking at an amnesic dementia with an insidious onset, gradual progression, and involvement of at least one additional domain of cognition. So that would be kind of the classic kind of Alzheimer's disease definition that really requires memory impairment. It requires dementia, so it requires loss of function and one additional domain of cognition. So the newer clinical research criteria are more flexible in more than one way. So these are the newer criteria that were proposed in 2011 by the NIA Alzheimer's Association working groups. And so it allows for, first defining dementia, in a general sense as kind of a condition where there is a loss of function in usual activities that might actually be due to non-memory cognitive domains, even in its early form. So it might even be behavioral primarily, if it's for example, like a behavioral variant of frontotemporal dementia. So there is this concept of dementia is broadened. The specific kind of concept of Alzheimer's dementia was also broadened to include some of these non-memory presentations of Alzheimer's disease that we'll talk about in a little bit greater detail. And then in other two sets of kind of papers, there was proposed kind of criteria really to broaden the concept of Alzheimer's disease as an entity that one might think about even when a person doesn't have dementia, kind of really based on the fact that, on the evidence that the pathophysiological process and the pathology starts to accumulate kind of well before a person first develops signs and symptoms of memory loss. And so, many of us are familiar with the concept of mild cognitive impairment, which is really distinguished from dementia by the preservation of function in usual activities. So, mild cognitive impairment, there's going to be objective evidence of cognitive impairment, but preservation of function. And then kind of a new concept really was this kind of preclinical. And this is really, it's not, I think, a really concept that we're applying in our clinics. It's really applicable in our clinical research efforts. And I think that this is still a little bit dynamic in terms of really the determination of what should be required for a diagnosis of preclinical AD. But in general, the thought is that there's kind of a very early asymptomatic period where it's really just evidence of pathology, and particularly the beta amyloid pathology. And then there might be an early symptomatic period where a person might have subjective concerns about changes in their memory, but might not test in an impaired range on formal tests. So that's, many people are aware that there's been more kind of publicity to subjective cognitive concerns being something that we need to take seriously, whereas in the past, I think we were more quick to say, oh, this person is worried well. They're worried about their memory, but we don't see any evidence of any problems. Don't worry about it. And I think in some cases, that concept still applies, but we also know that in some cases, really the person himself is more sensitive to the change than kind of what our neuropsychological tests are. These scans, just to point out, these non-amnesic presentations of AD that we'll talk a little bit more about. This is kind of a classic MRI for a posterior cortical atrophy. For kind of clear reasons, you can see how much parietal and occipital atrophy there is on the scan. And it's a little more subtle here. This is a patient who had progressive aphasia. And you can see that there's a little bit of left-right asymmetry here in the temporal and parietal area. Okay. So to kind of go through just what I'm talking about syndromic diversity in Alzheimer's disease. And so first we talked about the kind of typical amnesic Alzheimer's disease. So this is an episodic memory problem, memory for recent events, recent information. That presentation is roughly 85 to 90% accurate in terms of predicting the actual neuropathological diagnosis of AD. And that would be expert clinicians. It does, we're thinking about 10 to 15% of the time we're wrong. The posterior cortical atrophy, I think that I showed you the scan from that. We're really talking about what's been called a visual variant of Alzheimer's disease, and this is more people who are going to present with higher visual and higher kind of body awareness types of problems. So there are great kind of models for some syndromes like the Gerstmann syndrome, the left angular gyrus syndrome, the Bolint syndrome, the simultaneous agnosia and optic ataxia and oculomotor apraxia. In a general sense, I think that we're talking about problems integrating higher somatosensory and higher visual information that's really due to degeneration of the parietal cortex, the dorsal visual stream, and so the patients are not able to generate an accurate kind of representation of space. They can't shift their attention to hone in on targets, and they also have problems generating their own body representation, and so it's going to cause other problems such as apraxia as well. So that syndrome is usually due to Alzheimer's disease. So and there's not a whole lot to go on, but looking at the 40 or 50 cases that have been reported in the literature, about 80% of the time it is Alzheimer plaque and tangle pathology. Primary progressive aphasia would be neurodegenerative syndrome that really presents with language impairment as its initial manifestation. And we think of different subtypes of primary progressive aphasia. One variant that we think of has been called the logopenic variant, which is really marked by kind of trouble retrieving words in spontaneous speech. So the speech can be fluent and grammatical. Sometimes it can really appear non-fluent because of if the hesitancy is really profound and pronounced, there might be a real reduction of kind of verbal output. But what you're going to see is that there are these islands of preserved syntax and grammar kind of in a sea of trouble thinking of the word that a person wants to say. And you can pay attention in your typical Alzheimer cases too when they get to later stages, late moderate stages of illness, and some of the language problems that you see at those stages in a typical AD. Someone with a logopenic PPA might actually lead with those types of problems at presentation. So that is a little bit less predictive in terms of the clinical pathological association, and it's more about 60%. I think that was the number that that Mesulam and his colleagues at Northwestern, who have a pretty nice kind of clinical pathological series that they published in Brain, that was about the number that they came up with. Put the behavioral dysexecutive variant of AD down. I think that I have been fooled by this. I have diagnosed patients with more than once with behavioral variant of frontotemporal dementia, only defined later, neuropathological examination, that they had Alzheimer's disease. So it is an interesting phenomenon. I think that, we really think of 6 major, the most recent kind of criteria for the behavioral variant of FTD really would cite kind of 6 major elements, one of which would be apathy, one of which would be behavioral disinhibition, a third would be loss of sympathy or empathy, a fourth would be obsessive compulsive or perseverative behaviors, a fifth would be kind of hyperorality or changes in food preference, and then the 6th would be executive dysfunction. And I think that there's work to be done in terms of really understanding this behavioral dysexecutive variant of AD. What I would say, just from my anecdotal experience, that would be more predictive of AD versus behavioral variant of FTD is really the emotional responsiveness of the patient, how tuned in they are to the kind of nonverbal information that they're getting from other people. So there's a sensitivity, there's kind of a comportamental sensitivity to what others think about you that actually can produce a lot of anxiety in Alzheimer's disease, whereas you tend to see much more emotional blunting in the behavioral variant of FTD. And so I think the one single criteria that probably distinguishes them best would be the sympathy-empathy criterion. But we don't have any kind of diagnostic criteria for this behavioral dysexecutive variant of AD. And I think it is one, so we can't really provide a positive predictive value of the clinical diagnosis. It is an area where I think many times we miss the diagnosis in people in their 50s. We might attribute the changes to depression, to anxiety, when really it's AD with executive dysfunction early on. And then I mentioned the corticobasal syndrome, which is really a minority of the time going to be Alzheimer's disease pathology. So that was a bit of background, and I wanted to kind of set the stage to present just some research analyses. And this is where there were 2 different kind of research analyses that I'm going to talk about here. And the first one is really more aimed at looking at the question of different pathologies distributed similarly, presenting similarly. So this would be would be the 10 to 15% of times when we make a clinical diagnosis of Alzheimer's disease that's not corroborated by the neuropathological diagnosis. And this, the NAC uniform data set actually provides an excellent kind of illustration of this, where people who have a clinical diagnosis of Alzheimer's disease, who even thinking about more stringent pathological criteria, the positive predictive value of the clinical diagnosis is 83%. There's been a lot of work with amyloid PET and kind of amyloid biomarker, in vivo markers of amyloid pathology, and that would suggest kind of similar rates of low amyloid in people who have an amnesic dementia that are diagnosed with probable AD. This has already changed our practice in clinical therapeutic trials. Just the knowledge that a lot of people who were enrolled in a study like the bapineuzumab study, it was a phase 3 anti-amyloid antibody study. A lot of people in that study, particularly the ApoE4 non-carriers, did not have elevated levels of amyloid pathology, and yet they were randomized to receive an antibody targeting beta amyloid. And so the current generation of therapeutic clinical trials that really is involving kind of amyloid-based therapies is almost always requiring some sort of biomarker of amyloid as part of the screening and inclusion criteria for the study, to avoid this problem of giving people a drug that targets a problem that they wouldn't have. So I don't know how well this is projecting. So I'm going to try to summarize this. This is from that same paper, kind of from the NAC data set. And on the right side in this pie graph, I just tried to kind of break down and categorize some of the what were the primary pathological diagnoses in these patients who we thought had Alzheimer's disease who did not. And about a quarter of them had kind of a primary tauopathy, which could be tangle only or tangle predominant dementia or arteriophilic brain disease. Could be FTLD with tau pathology. Could have been PSP or CBD or or PIC disease or those tauopathies. There was a pretty substantial portion, about a fifth, that had primary pathological diagnosis of AD, but with low level of pathology. Some people had other FTLD, which at this point was just characterized probably as ubiquitinated inclusions, and then primary vascular, Lewy bodies, hippocampal sclerosis, and then kind of a smattering of others. So in the first analysis, I used the Alzheimer's disease neuroimaging initiative data set, and really just trying to look at what people in that data set were diagnosed with a probable AD dementia who did not have biomarkers suggesting elevated amyloid. And and trying to see really, do these findings, can we see any evidence that might support some of these other conditions that have been reported in the pathological literature, the clinical pathological correlation literature. And so with biomarkers, we think about ones that are more kind of direct and specific for pathologies, like biomarkers of beta amyloid. There's CSF A beta, which actually is low in people who have high fibrillar amyloid burden. There's flow beta pure PET. There is phosphorylated tau in the spinal fluid. ADNI actually used alpha-synuclein, which was analyzed here at the University of Washington. Again, low alpha-synuclein levels being more suggestive of a synucleinopathy, Parkinson's disease, or DLB, or multiple system atrophy. And then there's a white matter hyperintensity index in ADNI that was really analyzed at UC Davis. Charlie DeCarli and colleagues developed some tools to kind of quantify the level of white T2 changes in white matter. And then just also what are the kind of indirect measures that we might look at to try to gain more information. And so what are the clinical features of these cases? How do they compare to the amyloid, elevated amyloid cases? What's the CSF total tau, which is really more of a non-specific marker of neurodegeneration? Then what kind of pattern of atrophy or shrinkage do we see on structural MRI? And so just in terms of thinking about the clinical presentations, what has been reported for some of these kind of non-AD tauopathy cases and other pathological entities that might produce a kind of amnesic dementia. And what we see with brain disease and tangle predominant dementia and hippocampal sclerosis, well, more so for the former two, is that they tend to be more common with an older age of onset. There might be, there's no kind of clear consensus on the rate of progression, but there's a general tendency for a more gradual rate of progression. There tends to be amnesia in all cases, but there tends to be a higher kind of incidence of early neuropsychiatric symptoms in these entities compared to your typical Alzheimer's disease. And then there's a lower ApoE4, ApoE epsilon 4 prevalence. And then there's a pattern of atrophy that would be more kind of localized to the medial temporal lobe. Although I will say that with the tangle, the neurofibrillary tangle predominant dementia, I think it might extend beyond that as well. There's kind of an evolving kind of support for that. So this is what we had in the data set. We had 458 people who had an end diagnosis of probable Alzheimer's disease, who had at least one biomarker of beta amyloid. And this was including people with spinal fluid, people with flow beta pure PET, people with PIB-PET. We used kind of standard threshold criteria and categorized them as either low amyloid probable AD, which turned out to be about 10%, or elevated amyloid probable AD, and compared them to about 238 people with low amyloid who had normal memory and thinking. And what we found was that the age of onset was at an older age in the low amyloid case, and there was a lower ApoE frequency as expected. This shows just some, on the left it shows some global cognitive measures, and then on the right we've got more functional measures, and the CDR, Clinical Dementia Rating Scale, is kind of both a cognitive and a functional measure. And the point to illustrate in this slide is that the low amyloid cases have less cognitive impairment at an equivalent level of functional impairment. So that's kind of an interesting finding. And then we see that there's a slower rate of progression on the MMSE, on the ADAS-Cog, also on the CDR, and on the functional activities questionnaire. So these are, we are seeing a slower rate of progression in these cases. From a standpoint of more specific cognitive measures, this is just looking at the first acquisition trial of the Ray Auditory Verbal Learning Test, where we see kind of a similar level of impairment or change compared to the control group in both the low amyloid and high amyloid groups, but then a much more pronounced temporal limbic amnesia, as evidenced by recognition D prime on the auditory verbal learning test, and then also significant kind of differences between these low and high amyloid groups on trail making B-A, which is kind of a measure of executive dysfunction, set shifting problems, and then also on confrontation naming. So in each of these cases, the low amyloid group is impaired relative to the control group, but not as impaired as the high amyloid group. We did see that there was a greater level of neuropsychiatric symptomatology at diagnosis in the low amyloid group. So both on the neuropsychiatric inventory questionnaire and on the geriatric depression scale, there was more neuropsychiatric symptoms in the low amyloid group. So obviously, when we look at the beta amyloid markers, we're expecting, but by definition, we're actually categorizing these people based on these measures. But what I was looking for here is really, might there be still some difference between the low amyloid group and the control group, where you might see kind of a sub-threshold, increase in amyloid pathology? But these results are really not suggestive of that. Both the spinal fluid and the florbetapir levels were very comparable in the control group and the low amyloid group. So that would kind of argue against that sub-threshold level of amyloid pathology. And then on the CSF tau markers, what we see is that there's an intermediate level in the low amyloid group. So there is an elevated level of total tau compared to the control group, but it's not nearly as elevated as in the elevated amyloid group. And then there's no difference in the phosphorylated tau. The alpha-synuclein was a little bit frustrating for me because it looks to me like there might be a finding here, but it's a very small sample. So there were not a lot of people. I think only about 14 people in the low amyloid dementia group who had this measure, and so there's a lot of variance. So I'm reporting this. It's not a significant result, but there's a suggestion that there might be low CSF alpha-synuclein compared to, in the comparison of these two groups. And then I think very interestingly, there was a clear kind of greater level of T2 hyperintensities in the elevated amyloid group. And so, going into the analysis, I initially thought, well, maybe there's more vascular dementia in the low amyloid group, and so we're going to see a higher level of white matter hyperintensities. But actually, the people who have the Alzheimer's disease have the higher level of white matter intensity. So hyperintensities, again, kind of showing that there's a relationship there, at least in some people, and that the presence of the vascular disease is itself, I think, a risk factor for the plaque and tangle pathology. So looking at the cortical thickness, we see a very similar kind of pattern of change in these two groups. The left shows the kind of typical AD with elevated amyloid versus control, and then this is the low amyloid versus control, showing a very similar pattern of cortical thinning. So this, is pretty interesting. It's in keeping with some of the literature on suspected non-amyloid pathology in people who are pre-dementia, and some findings that there might be similar patterns of degeneration. And again, this is something that to me really supports network degeneration, because we know that these people do not have elevated amyloid, and yet they're showing a very similar pattern of change. And there's very little difference between the two groups when we compare them head to head. The blue areas are areas where there's greater thinning in the elevated amyloid, typical AD group, and so there is a little bit more, in the frontal and frontal areas and a few other areas, a little bit greater level of atrophy there in the elevated amyloid group, but it's not terribly different. So just to kind of conclude from this first analysis, there's not a lot of evidence that there's elevated fibrillar beta amyloid or phosphorylated tau versus the control subjects. There may be this alpha-synuclein, but I think it was not a significant result, so it's a case where we need more data to really assess that. But I do think the data suggests that a lower burden of microvascular ischemic disease than people with typical AD. Then looking at some of the more indirect information, that there was a slower rate of progression, it might suggest a less aggressive neurodegenerative process. I think that seems pretty evident. When you put that together with kind of the older age and the more prominent neuropsychiatric symptoms, these are the types of things that you would hypothesize to see from some of these entities, such as arteriophilic brain disease and tangle-only dementia and hippocampal sclerosis. And then when you put it together, the slower progression with less cognitive impairment for equivalent level of functional impairment, I think the conclusion is that it makes it much more likely that non-cognitive factors are contributing to to loss of function in this group. This would be in dealing with older people. They're going to have increasing contributions from loss of vision, hearing, other kind of problems that might actually have an impact on kind of both cognition but also function. And then I think the similar patterns of atrophy are going to, again, provide support for network degeneration. All right, so I know that our time is a little bit short, and second analysis is a little bit quicker to present. So I'm going to just try to show some analyses that illustrate the idea that similar pathology distributed differently can present differently. And so this is where we're looking at atypical cases of AD. And the background really is that we've known for a while that the burden of tangle pathology correlates better with levels of impairment. So this would be MMSE, and this would be correlations with neocortical areas, tangle in the blessed dementia scale, showing that there's a correlation here with the tangles, and there's no correlation here in the total count of plaques. So that's kind of long-standing. More recently, there's been even some more suggestion that in some of the atypical types of syndromes, that the tangle pathology is going to be more predictive for the type of syndrome that you're going to see. I mentioned kind of the Northwestern data set of progressive aphasia, and one of the things that they've illustrated is that when they've looked at tangle distribution in PPA that's due to AD versus typical AD, that there's greater asymmetry between hemispheres with greater tangle pathology in the left hemisphere in the PPA case, and that is not seen in terms of the distribution of plaques. And then this slide's a little bit hard to see, but this was a case series of several cases of kind of frontal AD, so more behavioral dysexecutive AD, and showing that, again, there's a greater distribution of tangles in the frontal cases compared to the typical cases, and that there was more of that kind of more discrepancy for tangles than for plaques. So what we did was to actually look at 6 cases, 3 of which had kind of typical AD, and then 3 of which had atypical AD, and we looked at both amyloid PET and tau PET, and then compared those results to the kind of more established pattern of degeneration by cortical thinning. And so this is our first typical case. This is the tau PET here. It's called AV1451, or also T807. And this is the cortical thickness map, which is really just derived by comparison against controls. So this is a z-score map, and then this would be the PIB map of the amyloid PET. And the finding is that there's that we looked at ROIs in both hemispheres, and found that there's a much better correlation between the thinning and the distribution of tau based on the tau PET than the correlation between the distribution of amyloid and the thinning. And that association held for all 3 of the cases of typical amnesic AD, and kind of with a pattern of tau uptake that really does kind of match the pattern of thinning. And again, this actually looks kind of similar to what I showed earlier in the ADNI analysis, where we were looking at kind of what regions of the brain were thinned in Alzheimer's disease. But then, when we actually move to the atypical cases, we see that the distribution of the tau actually changes much more than the distribution of the amyloid. So there's more kind of consistent pattern to the amyloid distribution in kind of these so-called default network regions. The tau does show us much more posterior uptake in this posterior cortical atrophy case, with kind of right greater than left hemisphere, which is also what was seen on the cortical thickness map. And again, there's a correlation between the tau signal and the thinning for tau that was not seen for amyloid. For the logopenic PPA case, we see asymmetrical greater uptake in left kind of temporoparietal cortex here, matching the asymmetric cortical thinning with kind of greater left than right hemisphere, but no kind of characteristic change in distribution of amyloid signal. And then in this cortical basal syndrome case, very interestingly, we see that there's peri-Rolandic uptake, which is pretty uncommon for AD. Usually it's going to spare the primary sensory and motor cortices until very late in the disease. And we see that the tau PET and the cortical thickness map illustrate that pattern, but we don't see that in the amyloid case. So really, I think that there's utility to both of these different types of PET. They're going to provide different information, though, and tau PET appears to have greater utility than amyloid PET to discriminate between these different syndromes that are associated with AD, and that signal is going to correlate much more with the neurodegenerative biomarker. So in summary, to try to put everything together, I think what I was hoping to illustrate is that these biomarkers of molecular pathology are improving our ability to make syndrome pathology correlations in vivo. I'm not suggesting that everybody needs to have these done. I don't think that in most cases, in our clinics, when we see a typical Alzheimer dementia case, that we need to, get all of these markers strictly for clinical purposes. But I think that what I was hoping to illustrate with the analyses is that in the low amyloid and amnesic dementia cases, that there is some indirect support for some of these alternative pathological entities that are kind of well described in the clinical pathological literature. And then also that there's some evidence of loss of function from non-cognitive factors, as I mentioned. And then in atypical AD, that the newer information from tau PET is kind of providing some corroborative evidence that distribution of tau is going to correlate with the clinical symptoms and severity better than the distribution of beta amyloid. And when we're actually putting things together in terms of what kind of an impact this has on our clinical therapeutic studies, we've already seen value, and I mentioned one example, which would be kind of selecting people for enrollment appropriately. So selecting people who actually have a molecular marker of a disease that we're targeting with the therapy. I think another huge kind of impact has been the opportunity for early intervention, which that's been a major emphasis, and it's why more of our studies now are targeting mild cognitive impairment due to Alzheimer's disease than people who have dementia due to Alzheimer's disease. And there are a smattering of trials that are looking at trying to lower amyloid in people who do not have significant memory loss. I think that the biomarkers are going to have have the clear potential to have better endpoints. And this clinical heterogeneity just introduces noise into the signal. The studies are designed with endpoints that are really designed for typical Alzheimer's disease, and it's not going to capture some of the other impairments that people with aphasia or people with visual dysfunction have, and yet there's a spectrum, and people enter studies with kind of a lot of phenotypic diversity, and it's just going to be problematic when we're actually using memory endpoints to assess progression of people who have primary problems in areas other than memory. And I think the other kind of potential is to really try to more rapidly test efficacy in our potential disease-modifying agents, so that before we commit to doing large placebo-controlled, double-blind, 2-year plus clinical therapeutic trials, maybe we can use biomarkers to really test our agents, before we invest the substantial money and resources for those studies. And then, I think the vision that I have, and that, I think a lot of people have, is that with better biomarkers, we're going to have more of a potential to target multiple mechanisms in individual subjects. And I think we've seen how molecular genetics has really revolutionized cancer treatment. And even prior to that, we really usually treat cancer with multiple drugs that target different elements of the process. And this is a different case. Obviously, we've got degeneration. It's kind of the opposite problem, but it still is the case that there are multiple mechanisms at work in Alzheimer's disease and in other neurodegenerative diseases. And I think that when we are able to actually target different pathways concurrently, it will improve our chances of success, but we need the biomarkers to help us in that process. So I just wanted to kind of acknowledge my collaborators, including Dr. Demoto O'Reilly and David Wolk at the University of Pennsylvania, and then some of my colleagues in Brad Dickerson's lab at MGH, and then, of course, the Alzheimer's Disease Neuroimaging Initiative. Thank you.
Thanks for a great talk, Scott. So you mentioned that in the low A-beta probable Alzheimer's disease patients, that they have more neuropsychiatric symptoms. What were those symptoms, and do you think that those are contributing to the similar rates of functional impairment?
Yeah, so I think that's a great question. I actually haven't done the analysis to really answer that, other than I think that depression is one element, and we know that from the geriatric depression scale. The neuropsychiatric inventory questionnaire is going to have different items that kind of contribute to the global score. So it can be hallucinations, it can be agitation, it can be apathy, it can be changes in eating behaviors, it can be changes in sleeping behaviors. So there are a lot of possibilities, and I think that's an analysis that remains to be done to really see kind of what sort of pattern or profile of changes there were in that group, but I haven't looked into that yet. And I do think that yes, it is possible that would be a factor that might contribute to dementia and contribute to functional impairment. That would not be captured in those global cognitive measures, the ADAS, the MMSE. So, I was just kind of hypothesizing about the changes in primary sensory modalities, but it very well could be, contributions from other factors like neuropsychiatric symptoms too.
Okay, thank you.
Following up on that, so you made the association of some of these symptoms with pathologies that we usually think of as hippocampal limited, so UGD or hippocampal sclerosis, for example. Is there evidence of the anatomic involvement outside hippocampus, or do you want to speculate on what the mechanism is?
Yeah, so I don't, I would say that, and all I know is from my own review of the literature, not being a pathologist. I think that, yes, by and large, for grain disease, it does seem to be mostly medial, temporal. There might be some spread outside of that. I think that it's very hard to find clean, cases. I mean, it's hard to find people that have pure grain disease. And I think there is some controversy in terms of thinking about it as a pathogenic entity, because more often than not, you have somebody who has grains, and then they might have some Lewy bodies and some vascular disease, and they might have additional pathologies elsewhere that might be contributing to the presentation as well. And I would make the similar argument for hippocampal sclerosis, particularly given that there might be, a greater, incidence in like TDP pathology, in people with hippocampal sclerosis as well. So, yeah, I mean, I think if it's really strictly medial temporal, it's really hard to think about how that's going to contribute purely to neuropsychiatric symptoms. I guess there are certainly paralimbic areas that are closely affiliated that might produce those symptoms as well.
Yeah, it seems like a clue.
Yeah, yeah.
It's tough to talk to the patients and their families in these cases that have atypical presentation, isn't it? That if somebody has posterior cortical atrophy and they have an 80% chance of Alzheimer's, or they have primary progressive aphasia, 60% chance of Alzheimer's, and they ask you, do I have Alzheimer's disease? And they ask you, should I be on an anticholinesterase inhibitor? Should I be on Namenda? It's hard to talk to them about that. Well, you have an 80% chance of having Alzheimer's, you have a 60% chance of Alzheimer's. Do you think those are the people that you should go ahead and get PET scans on and do the spinal fluid analysis? Or should you just say, well, you might have it, take the cholinesterase inhibitor for a few months and see what happens? Or what do you think your best approach is?
Yeah, that's Yeah. Oh, yeah. So I'm going to repeat the question, and
That's a long question.
yeah, to paraphrase the question, I think is, you know, when dealing with atypical presentations, a syndrome like posterior cortical atrophy or primary progressive aphasia, the logopenic variant, where statistically the probability might be that the patient has Alzheimer's disease, how do you communicate the diagnosis with the patient and their family, and are you more likely to kind of seek additional biomarkers in those instances? Are you going to base treatment decisions, you know, on that? Would you be more likely to prescribe a cholinesterase inhibitor or memantine for an atypical case if there is evidence of AD as the cause? And I think that to answer the different levels of that question, I think first of all, it's just very valuable just to explain things, you know, beyond the label to the patient, and to actually just take the extra time to bring them to an understanding that, you know, that this is why we are dealing with these symptoms, and these are the different possibilities, and that, you know, Alzheimer's disease might be a possibility, but it's not the Alzheimer's disease that most people are familiar with. And the education is really, really important, I think, for these, and then even for other kind of non-AD dementia syndromes, because so many patients and families are going to be getting so much input from a lot of sources that, you know, people say, oh, you know, my parent had this, and this is what I did, and it can be alienating to have a different syndrome and to have other people telling you, you know, what they think you should be doing when you're actually dealing with a very different entity. So I think, first off, that communication is very important. I would say that I think specialists are generally more likely to pursue the extra testing in these cases for multiple reasons. I think many times they are younger patients too. So I didn't mention this, but I think a third of, you know, early onset, you know, AD cases, sporadic early onset AD cases, are going to have one of these atypical presentations. And we tend to be more aggressive in trying to establish a diagnosis for a variety of reasons. I don't think that you necessarily need to defer your treatment. So I would say that we don't know, even for atypical AD, whether there's more likely to be a response to cholinesterase inhibitors and memantine. You know, so we can't say that somebody who has posterior cortical atrophy due to AD, you know, that we have the data to say that using donepezil or a cholinesterase inhibitor, that they're going to respond to that better than somebody who has posterior cortical atrophy that's due to cortical basal degeneration. You know, so these are unanswered questions, and I think that my practice is kind of my practice for mild cognitive impairment too, and you really think about these questions individually based on the value of the information to the patient. How important is it to have a more specific diagnosis? Is this somebody who might be interested in a therapeutic trial? You know, do we want to get the information in the context of screening for a therapeutic trial? One of the main purposes of the IDEAS study, which is a study that's being sponsored by the American College of Radiology, is to basically look at Medicare eligible patients, so people who are 65 and older, who have who meet the appropriate use criteria for amyloid PET, which basically means that they are atypical, and really seeing whether having this information changes the clinical management. So that's what we're looking for. And you know, the clinicians are completing forms before the PET scan and you know, and after the PET scan based on kind of the counseling and the medical decision making, and because it's kind of a unique position to be in with amyloid PET now, where we've got FDA approved studies, you know, 3 kind of FDA approved ligands that are not covered by insurance. and with prohibitive cost. So I think the study will be important to kind of answer some of the questions that you raised.
So you made a good case that the cortical thickness tracks the tau deposition pretty well. Do you think we ought to be measuring cortical thickness clinically? Do you think that would add value to our clinical workup? We often do high resolution MR scans, but we leave that information on the table because we don't post-process the data.
Yeah. Yeah, I think that yes would be my short answer. I think that there's a lot of data that we routinely collect that we could analyze in a more sophisticated manner to actually give us more information than our clinical reads, and just looking grossly for atrophy. That being said, I think that what I'm showing and what Brad Dickerson kind of showed in some of his work, where he was looking at kind of the regions of thinning, the cortical signature of AD. These were analyses that were group level analyses, and so how well that translates into individual patient biomarkers. It hasn't been established. I think that's been kind of on the agenda to try to do that in a more sophisticated way, but it's not something that has been developed yet.
I think your results with the white matter hyperintensity said they were not that different in the amyloid negative group. They were very similar to the controls. It's very interesting. In some of the work that I've done here, we found that people with ApoE had higher white matter hyperintensity burden. And there's essentially a very big difference in that ApoE equal carrier concentration and amyloid negative and amyloid positive groups. Do you think that that's the reason you're seeing this difference in white matter hyperintensity?
So the question is, on the finding that the white matter hyperintensity index was higher in people with elevated amyloid and dementia compared to the group with low amyloid. Putting that in the context of other research that has kind of shown an association between ApoE, epsilon 4, and white matter hyperintensities, and whether the ApoE might actually be driving the signal, right? Is that, I don't know. I think what's really hard is to really tease apart those factors, because there's a pretty strong relationship between amyloid burden and the epsilon 4 status. So it's not as if we have a lot of people that are epsilon 4 carriers, with low amyloid, to try to see if there's an independent effect. I do think that and again, this isn't an area that I would say I am an expert in, but I still think that there are important questions about even what drives the hyperintensities, and we suspect that it's vascular. Is it, how convinced are we that it's arterial versus venous? How heterogeneous is it? How many different mechanisms might give rise to a T2 signal change? So I think what's kind of interesting, though, is that it definitely, I think pathophysiologically, this is where, why is there this association? And why is there this association in some people and not other people? And again, what are the specific routes that actually lead to the plaque entangled pathology?
Do you think there's a right hemisphere counterpart to low leukemia?
Yeah, that's a great question, and I So I think I would answer that question differently than Brad. I think Brad Dickerson, again, I've talked to about this question. I think he suspects that like a fair number of the posterior cortical atrophy patients are asymmetrical and they're more right kind of parietal than left. But I don't know, it's seemed pretty symmetrical in my experience. I think that some of the corticobasal cases are actually more like right hemisphere analogs, homologs, excuse me, to the lobopenic, because I think that with that kind of right parietal degeneration, you get clear asymmetry, and you get kind of a combination of neglect and apraxia and kind of higher cortical sensory changes that can also impair movement, and so you need to be very real stringent and really try to tease apart, okay, is this person slow moving because they're kind of relatively deafferented, or are they slow moving because there's an extrapyramidal, bradykinesia, because you might get myoclonus, you might get other things too. So that would be my kind of thought, is that some of the people that we call corticobasal syndrome due to AD really don't have too much of the basal component, but they might have the cortical component that is kind of giving that appearance. All right. Well, thanks, everybody.